Research is the cornerstone of innovation in clinical practice, driving improvements in patient outcomes and shaping the future of medicine. Welcome to the Global Rhinology Network Topical Research Symposium. I'm Ashok Rokade from Winchester, UK, and it is my privilege to welcome you as a host. Joining me as co-hosts are Louise Melia from Bath, UK, and Professor Thibault Van Zele from Ghent, Belgium. This symposium showcases fascinating topics across 4 key modules: General Rhinology, COVID session, and Research in Chronic Rhinosinusitis. A special highlight is the PhD session featuring research conducted by enthusiastic young rhinologists who represent the future of our field. This symposium brings together leading global minds in rhinology who will highlight latest developments with a focus on translating research into impactful patient care. The Global Rhinology Network is dedicated to advancing knowledge innovation. Thank you for being part of this exciting journey. Thanks to Medtronic and Karl Storz for their generous support in making this symposium possible. Welcome to GRN-Topical Research Symposium.
Our next speaker, Professor Robert Kern, is the chair of the Department of Otolaryngology, Head and Neck Surgery at Northwestern Memorial Hospital in Chicago. He's also Professor of Otolaryngology and Medicine, which includes allergy and immunology. His research is focused on the pathophysiology of chronic rhinosinusitis. And as Ashok has said, today we're going to hear, which I think will be extremely interesting, especially given the last talk, what are the limits of current biologics for CRS with nasal polyps? Thank you.
Well, thank you. The first challenge, we'll see that if I'm able to share my screen. I think that worked. Can everyone see that?
Yes, that's great.
Okay, good. Perfect. Well, first of all, thank you for including me. Hopefully you'll find this interesting. I think it plays off well on the earlier talks we've had. I have no relevant conflicts. Most of us now think of the nasal and sinus mucosa as sort of the site of a host environment interaction. Like any epithelial or mucosal surface, it forms a kind of barrier. And in a typical patient, we inhale many different things, and they're usually trapped in the mucus and dealt with, swallowed. In some cases, there's acute viral infections, bacterial infections, but these generally resolve. But in CRS, there's a penetration and a self-perpetuating inflammatory reaction. Now, this is a drawing here of the multi-layered mucosal barrier, the static barrier, then the innate and the adaptive immune system here. But in CRS, the barrier is penetrated, and there's this self-perpetuating inflammatory reaction of effector cells and as well as T and B cells. So if you think about it, and back up and think about it, this host and environmental factors interacting for typically 4 decades or more. The barrier's penetrated, and CRS is the result. Now that brings up a number of questions. First of all, why does this occur? And what are the key antigenic drivers? And what drives the type of inflammation, or endotype, if you like, that we see in an individual patient, and how can any of this knowledge improve treatment outcomes? Well, along the road, and perhaps this was the work of the Mayo Clinic, we got perhaps a bit sidetracked into looking at what was driving the process, causation. Number of different ideas were proposed, a bunch of work was done, some of it very good, and very helpful later on. But unfortunately, it didn't lead to much treatment progress. I was thinking of Klaus's comment about the progress in the last 10 years, and that's about the last 10 years that, we still were kind of empiric, antibiotics, steroids, and that really didn't move the ball forward very much. Well, synchronous to that, there was this sort of worldwide movement to look at personalized medicine and studying the phenotype, genotype, and endotype of diseases. And we're all more or less familiar with these. But if you look at CRS with that, the genetic factors, the studies that have been done, the NIH refused. We asked, I can assure you, the NIH refused to publish true large-scale GWASs. But the work that has been done suggests that there are multiple genes involved, each probably with a small effect size. Epigenetic factors are probably more important because this is an adult onset disease. And maybe there's a couple ALOX 15 or perhaps CFTR that are more important players, but they're not a huge treatment breakthroughs there. And there's the phenotypes, and we can try to subdivide that, and I'll do that in a second. And then the endotypes, which are sort of the underlying focus today. So really what you saw was a shift here from left to right. Rather than an interest in causation, we looked at result. And how can we divide the patients by result in the hopes of improving treatment? Now you can look at phenotype, and this is really based on the work we did with Bloomberg School as well as Geisinger. The epidemiology has really been understudied, but this is a downward estimate here, because you'll get people saying there's 35,000 people in the United States with CRS. It's probably a more realistic estimate for the number of people with sinusitis, and you can try to divide them into the different phenotypes. And this is somewhat useful. You can usually tell when the patients are going to do poorly. The problem, the limitation here is that not a lot of patients do not have, and probably the majority of patients do not have a true advanced phenotype or something you can really define. And there's still variation even within AERD patients, which mostly all do poorly, but some of them do a lot worse than others. So phenotyping alone has a sort of limit. So then there's interest in endotypes and the real mechanistic pathways. And we think endotypes are important because they drive the phenotype. They also drive remodeling, which helps drive the phenotype. And perhaps they also determine the nature, the existence and the nature of lower airway disease. So what are the endotypes? Well, there's no real clear agreement quite yet. There's a number of different proposals out there, but they must have clinical significance. So this was the first very influential paper from Ghent. And all of you are familiar with this. And the number of cytokines, chemokines, ratios, other factors were assessed to do a cluster analysis, and then the results, the 10 results here, one didn't really fit any pattern, but the others were organized based on IL-5 expression. And this correlated nicely here with the presence of polyps and asthma, which is a surrogate for at least surgical outcome, probably medical outcome too. So this was informative and sort of points us in the IL-5 direction. This is another study here from the group of Wuhan, similar idea, but much more extensive. Many more factors were lumped together. These are Chinese patients, not Western patients. And a cluster analysis is done here. They come up with 7. And this is a little bit hard to apply, but it's intriguing for a number of reasons. I won't go into them in detail. And then our group kind of took a very sort of simplistic approach, not based on the known immune responses across the epithelium. And it relates to the others, but it's just a little easier to wrap your head around, either antiviral, anti-parasite, or anti-extracellular organisms. And these pathways are more or less, the idea being they're more or less hijacked in sinusitis. And this is some unpublished work here, but it doesn't say anything particularly striking. It's the effector cells and the source cells for the cytokines, which then we think drive remodeling and also phenotype. But it's difficult to separate these patients based on clinical signs, particularly 1 and 3. They both have pus. Going beyond that, it's not particularly easy. The type 2, clearly the smell loss and the higher incidence of polyps in Western patients. So if you use that methodology, there's 8 possibles with, again, one that's not particularly typable, similar to the group 1 in the Thomason paper. When we looked at our patients, you could see here about 87% or over 80, between 80 and 90% of the polyp patients have at least some type 2 signal, and 55% of non-polyp patients have some type 2 signal, although some of them are mixed. And this is really similar to the results in Europe and Western patients in general. It varies across the globe for genetic, probably more importantly, environmental reasons, but the end result is 60% of our patients have some component of type 2. And the importance of type 2 is because we believe it's associated with treatment failure. And if you're talking about 60% of patients total, with an increasing prevalence around the world, that raises the question that we should maybe be focusing on this. Now, fortunately, the biologics have emerged, which specifically target type 2 inflammation. And this is a drawing here, was done by Jackie Schaffer, who's Bruce Bachner. Many of you know Bruce. This is his wife, who's also an immunologist. But it demonstrates the barrier penetration, stimulates the alarmins, which drive innate lymphocytes and dendritic cells here to mount this type 2 response. IL-13 is pivotal in the remodeling, epithelial and polyp-wise. IL-4 drives the B cell response, particularly IgE, but there's also many other immunoglobulins that arm the effector cells that are drawn in. And there's probably some 4 and 13 redundancy here, but the end result is a diagram of type 2 inflammation. Now, I mentioned polyps, IL-13. Well, I didn't mention polyps. I mentioned remodeling. And polyps, we see that as a form of remodeling. IL-13 here is pivotal. It both potentiates the fibrin cross-linking, which is the stuff of polyps, and it also suppresses the TPA, tissue plasminogen activator, which breaks down fibrin. So for 2 reasons, it fosters the process. IL-13 also turns neutrophils to the, I won't say the dark side, but it turns them to generate OSM, which is probably physiologically important in regeneration, but that creates this immature leaky barrier. So this is modified from the original publication from my collaborator, Bob Schleimer. Barrier is penetrated here in type 2 inflammation after 4 decades of exposure for reasons we don't understand. The inflammation is skewed in the type 2 direction, which we also don't understand. And we could talk about that if you want, but that's a whole nother lecture, and I wouldn't have too much to say about it. But the type 2 cascade here, which is probably self-reinforcing, and we're describing it here in a linear fashion, but it's probably more of a matrix type fashion. But the key cytokines here, as well as other factors, further weaken the barrier, make it leakier. And, I sort of wrote the concept here of barrier failure. And what I mean by that is that the epithelium is now unable to keep out further antigens. So you're going to get further type 2 inflammation. And this is kind of a self-accelerating process, like a snowball rolling downhill. And when you reach the certain point in a particular patient, you will suppress the TPA and foster polyp formation. And by this analysis, or by this hypothesis, the formation of polyps is a function of disease intensity. It is not a separate disease. And that's an important idea. Certainly the NIH doesn't quite get it yet, but it's an important concept, I think, at least a workable hypothesis, a testable hypothesis. So, and interestingly, from the work from Wuhan, that the polyps in the type 1 patient or also the type 3 patient also appear to suppress TPA. So it suggests that disease intensity is also operating in those patients, which are, of course, less common and more difficult for us to study. Now, barrier damage, I alluded to that as being sort of the accelerant here of the process. It appears to be less prominent in non-type 2 inflammation, and I would argue that that may very well be the reason for the chronicity and the relapse potential of type 2 inflammation. but there are a lot of questions that remain. Are there type 2 subendotypes? Almost assuredly. I mean, we see that already, AFS versus AERD versus others. And what about when there's a mixed non-type 2 signal in there? What does that mean? Well, we really don't know. But the work from the Jezrek group here is still pertinent. And they would suggest that it's not just the presence of type 2 inflammation, but the intensity, which is associated with treatment failure. And intensity is, again, I was laying it out, the argument that it's a surrogate for the presence of polyps. Maybe not always. Some people may be more sensitive to foreign polyps than others because of factors that are understudied, maybe TPA levels or other things, but it's a surrogate. And the Jezrek paper here, Tokunaga, does suggest that when you look at the tissue eosinophil levels, there is an association with treatment failure. It's cleaner when you divide them by more or less than 70. But then they did another surrogate here for tissue eosinophils, and that they created a Jezrek score, which is a number of different observable pre-surgical points that you can look at. And when you combine them with these factor A and factor B, you can come up with four measures of essentially tissue eosinophilia. And when you divide that out, that clearly breaks down nicely as the eosinophil is the more or less the key cell type indicating recurrence. So we have three approved right now for at least for polyps biologics. One would that data would suggest that mepolizumab should be, or targeting the IL-5 axis should be, the most effective. And really, this is looks kind of small here when you look at the full-blown type 2 inflammation. But there are two ways, or at least basic ways, to target it: either targeting the receptor itself, or lapping up or sequestering the IL-5 itself. And they work a little bit differently, but benralizumab, that targets the IL-5 receptor, was significantly less effective. In fact, the FDA did not approve it for polyps. And one was sort of, that teases the question of why. Now, putting aside that it could be the antibody itself, that seems unlikely since they both work in asthma. But if you look at the cells that make IL-5 versus the receptor, the eosinophils clearly die when you either take an IL-5 away or you bind the receptor. It suggests that maybe what's missing here, or what's also playing a role, are the B cells, epithelial cells, or neutrophils that have these IL-5 receptors, that maybe the signaling is still getting through. Now, this is from the type 2 or the phase 2 trial, but mepolizumab clearly does shrink polyps. And benra failed. And then you also have this idea that, or this paper that came out from Tanya Laidlaw's group, that this dexpramipexole, which is an ALS drug, which sort of incidentally takes away all the eosinophils from the blood and the polyps, but it didn't shrink the polyps or improve symptoms. Now, she suggests that mast cells are the operative factor. I think the evidence for that is weak, even in the paper, but maybe, who knows? It clearly, eosinophils are not the complete story, however. Now, if you turn your attention to the others, here's anti-IgE, and that I have it circling here only the mast cell degranulation arm. It probably, IgE does other things, tickling the dendritic cells and maybe other cells in the pathway that's been less well studied. And it works at least as well, and maybe better, surprisingly, than mepolizumab, at least in the phase 3 trial. So again, it sort of de-emphasizes eosinophils. Now, when you look at dupilumab, this strikes the IL-4 alpha, or blocks the IL-4 alpha receptor, which is a shared receptor. So you get a 2-for-1. You knock out both 4 and 13 signaling, which may have an element of redundancy in vivo. And this takes a bigger chunk of the a larger portion of the cascade, of the type 2 cascade. And certainly the polyp shrinkage is more effective, or greater. And what's also intriguing here, I don't know if you can see my marker, but there's a downward trend in both of these, that 52 and 24 weeks, which suggests that if you gave the patients, as opposed to the other biologics, which level off, suggests that maybe that if you gave the drug long enough, that the polyps would disappear completely, and the nasal congestion would be gone as well. That remains to be proven, but it suggests that. Now, when you compare these, and this is an artificial study here, artificial slide, because there have been no head-to-head studies to date. So take this with a grain of salt, but everyone looks at these sort of comparisons. And again, I like, as Klaus alluded to, I think the polyp score is a cleaner way to look at it, and you compare dupilumab at 1 year particularly, it's quite a bit better. But even how powerful these are and how important we know that type 2 inflammation is, there's still a lot of patients that do not have major polyp shrinkage. If 85 or 87% of the patients, and these are all really almost assuredly all Western patients on these trials, why are we not doing better? Well, that's a good question. And again, that also to me suggests that other cells that are not classic type 2 cells may be doing something here. And particularly maybe the B cells or the neutrophils. Now, B cells, again, are sort of forgotten here in a way, except for the IgE, but there are other immunoglobulins. Klaus's group was the first to show that. And it's not clear to me that that's going to be driven by IL-4. Now, we don't know, whether BAFF is a driver here and that is driven independently. Perhaps it is, and perhaps that's not getting blocked by any of these biologics. So you're still getting breakthrough autoimmunity or other factors kicking in. And also, this is a study that didn't really get a lot of noise here, but it was from using the GESREC data, and their group of patients, now separate, who knows the surgical criteria, et cetera, but they did not see this huge difference between non-eosinophilic and eosinophilic. And except when you start breaking it down to the really severe patients. And their study, intriguingly, here shows that tissue eosinophils were in the eosinophils and neutrophils in the non-eosinophils. So it suggests anyway that there are at least two pathways. And neutrophils, I mentioned before here that they do things here, the type 2 neutrophils in our work. And then this is from Klaus's group here, suggesting that the neutrophils are doing other things here with their elastase and cathepsin enzymes here, damaging the barrier. So kind of working in a fashion not dissimilar to the, different mechanism, but also in effect making the barrier leaky. And then this is a recent paper from our group, which here, that if you look at the middle panel, eosinophils and neutrophils are not correlated. So the pathways are independent. So the neutrophils are either coming from type 1 or type 3, or perhaps even an independent pathway that we have not really identified. And neutrophils here are actually even more accurate predictor of treatment failure, high neutrophils in the tissue. So neutrophils are present in all forms of CRS to a degree. Is that a superimposed endotype, or is it secondary to what's already there? Is it secondary to tissue damage? And clearly it may interact with the eosinophils, or at least be changed in a type 2 environment. And there's some evidence that, again, these mixed patients are worse. They're going to be steroid resistant. They're going to be biologic resistant. And there are some anti-neutrophil drugs that are emerging. Whether the ones that are going to be available are helpful or could be partnered with a biologic is an intriguing idea going forward. So my belief is that the intensity of T2 is associated with treatment failure, but so is the neutrophils, and also even with maybe a moderate type 2 inflammation, they're able to push the patient into a more severe category. And then we probably need to explore whether there are separate subendotypes and whether they can be interdicted separately or in a more personalized, to jump back to the earlier slide way, and whether we have really identified all the endotypes. There are the patients certainly that we haven't characterized, these untypable patients, but that's perhaps a task for another day. And then the question about whether to use them pre or post-op, I have adopted using them post-op. Everybody deserves a surgery, in my opinion. I follow them closely. If they start to fail early on, I will use a biologic. You can talk about the cost efficiency, but when it's $38,000 a year for biologics in the United States, the cost of surgery is a drop in the bucket. And I think there's a difference in treating a patient, and Klaus was alluding to this as well with the reboot. If you take a patient with a polyp score of 0 when they're regenerating, if they're regenerating their epithelium in a type 2 environment, they're going to have a higher chance of recurring. If you block type 2 inflammation with, especially with the IL-13, IL-4 blockage, I think the regeneration is going to be far more normal. I think we're asking the drugs to do a lot less if we give them in the post-op setting. And in my own personal experience, my success rate skyrocketed using this methodology. I'll just show you a couple patients here. This was a 4-time failure, AERD patient, had already failed omalizumab. Rick Chandra had done the last 2 surgeries on him, and I inherited him when he moved to Vanderbilt. Mepolizumab was just coming into play. I used the draft 3, and we gave him, and here you can see 3 years later, he's essentially cured. And he was a grumpy patient, and here is his endoscopy 4 years later. So this sort of sold me. And here's another patient here, another 8 months out from a prior surgery, and look at his, he's on omalizumab, failed aspirin desensitization, and his nose is a mess. So I did the same, again, put him on mepolizumab. It wasn't as effective. It started to fail here after a couple of years. He was switched to benralizumab because we didn't really have any data on benralizumab at that time. That didn't work either. And he ended up going on dupilumab. And here, although he looks like he's got some disease there, he can smell. He has almost no symptoms. He is very, very happy. Now, just to sort of muddy the waters, here's a patient. This is not my patient, but an Asian American who had surgery. I think it was 8 months earlier, and the nose is a mess. Now, the pathology shows something, not the typical eosinophilic inflammation here. And this is the slide of her endoscopy here. This is presenting here 8 months after surgery. The nose is a mess, pus and polyps. Patient, the question is, what do you do here? Pathology suggests not a biologic. And this patient went on 3 months of low-dose macrolide. And this amazing response, absolutely amazing. The patient is cured. Now, you could argue, when can you take him off this drug? That's another argument, but this is clearly a dramatic response. So, and then just again, to further muddy the waters, this was a patient that I was ready to apply my current treatment algorithm, and she got approved for dupilumab, but disappeared because of COVID. She came back 8 months later. I got a CAT scan, and she said, "Doc, the medication didn't work. I can't breathe." And the reason here, she's fully decongested here. Her turbinates didn't shrink at all. This suggested to me that dupilumab works great on polyps, but it doesn't really affect inferior turbinate hypertrophy. So in the office, I reduced her inferior turbinates, and she's happy as a clam. So, but the problem is distinguishing this patient from patients who maybe won't have such a robust response. Ben mentioned cystatin. That's been proposed as the perfect biomarker. We can't duplicate those results. So I don't have the capability to predicting this patient from the patient who will have a little more muted response to dupilumab. So I think that's my last slide. I'd like to recognize the rest of the team. I'm merely the surgeon here who has the great honor and the pleasure to work with a wonderful team here. And I'd be happy to the degree that I can, answer any questions. Thank you for your attention. I've left everyone speechless.
Yes. Are there any people from the panel who?
I want to ask a question.
Yeah.
Bob, very nice presentation, and I like your way of thinking. You are struggling with the same things that we are struggling with. But on benralizumab, I want to ask what you think, is it the mechanism anti-IL-5 receptor anti-IL-5, or could it be that it's a dosing problem? Because all the dosing is done not on nasal polyp disease, and we know that IL-5 receptor regulation, for example, you get very insensitive situation in the tissue compared to bone marrow or blood. So maybe, and also then they switch from every month to every 8 weeks of dosing. Could it be just that the dosing is wrong and that they did the dosing on blood eosinophils and tissue eosinophils rather than on the effect on the other things? Or do you think it's more profound that anti-IL-5 receptor is a different target than anti-IL-5?
Well, I mean, I really don't know the answer. I mean, it works in asthma. You know, one would expect that it would work in polyps. You know, we're going to see, you know, these different type 2 diseases are a little bit funny. I agree. Dupilumab seems to be the only one that's kind of run the table and has an approval for just about everything. But I mean, you raise very good points. I don't know. I was a little bit disappointed with the response of mepolizumab as well. So that leads me to think that maybe and I believe benralizumab was chosen as a drug, or chosen because it was so effective at killing eosinophils, the eosinophil apoptosis. So, but I don't think they looked at any of the other cells that it was interacting with at all. And, you know, maybe those other cells, structural cells, B cells, are more important in nasal polyps than they are in asthma. But you know, your question is spot on. Is that a mechanistic issue, or is it just basically trial design? I don't think they have the enthusiasm to go and do the trials, however. But you know, you're right. I don't know the answer.
So thank you, Robert. I have a question, and it's probably jointly for yourself and to Klaus as well. It is about the cost factor of the biologics. I mean, the healthcare systems, which are socially funded, like our NHS in the UK, we have a job at hand to approach for approvals. So what will be your suggestion to make a strong case, make a strong argument for the use of biologics?
Well, I think the answer hopefully will be a biomarker that tells you who the super responders are and distinguishes the herd. You know, for the United States, I don't know, there's a few million polyp patients. Not everyone needs a biologic. You know, if you give it to everybody, that will, you know, tank the system. So who should get it and who shouldn't? You know, the problem in the United States is that it may be used to make up for inadequate surgery. Jim Palmer, I think he refuses to use any of these biologics because of that reason. But there are people that will do substandard surgery and give like people that used to do substandard cancer surgery and then expect the radiation to clean it up. So what goes forward? I think the biomarkers are the best, you know, cleanest answer. But beyond that, we're all struggling with this.
I think a little bit the solution to that would be that you have centers where everything is available to treat these patients, and you can make really decisions in all directions, and you're not bound to the one because you need to earn surgery money, or the other because you can't do surgery. So it's very important, I think, that this might be multidisciplinary also, because you have asthma as a very important disease in here. That in the future, when this is even more than today used, that might be a little bit of a, how do you say, a consortium, a gremium, some people looking at it and coming from different sides and have different views on the diseases to decide on that. I mean, at the moment, if I'm right, in Europe, I don't see really that it's costing billions already. I don't know what is happening in the US, but probably, of course, there's an increase in usage of biologics.
There's a
Thank you.
tremendous
That's
increase in use in the United States, and particularly dupilumab. I think they've, for the most part, won the war, at least in polyps,
Yes.
and probably in everything, because they have the broadest. Now, whether TSLP can if you can go upstream, as Ben was talking about, perhaps, but TSLP didn't work, and shockingly, didn't work in atopic dermatitis. I still can't wrap my head around that, and nobody can tell me why yet. So
You have to do it one by one, these studies, right?